Now I have the Davies. Good afternoon, and welcome to the Davies Use Case webinar being presented by Children's National on Head Quality Boards, a paradigm shift, engaging providers and patients in quality improvement. This is a Davies Award use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health IT to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. This recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. The Davies Awards winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT-enabled care delivery. It's my pleasure to welcome our speaker today, Dr. Craig Futterman. Dr. Futterman has been heavily involved in IT since before medical school in the mid-1970s, when he programmed on IBM 370 mainframes. While in his residency, he programmed medical simulations teaching residents and students. As an attending physician, he created software for the Department of Pediatrics for keeping track of attending physicians' credentials. He created software for pediatric residency and software for billing and tracking quality of care, as well as communicating to outside physicians in the pediatric ICU. He's been practicing pediatric critical care for 30 years, and the last 6 have focused exclusively on pediatric cardiac intensive care. At Children's National, he has developed a software for continuous quality improvement and for communications with outside and referring physicians. Welcome, Dr. Futterman, and I'll turn the presentation over to you.
Thank you very much, and it's a pleasure to be able to give this presentation. We're very proud of the work we've done here. Next slide. Have a local problem with which all hospitals struggle. The core problem is to accomplish. For one thing, clinicians are very busy people. Next slide. They have things to do. So a nurse, for instance, will have to give meds, start IVs, draw blood, suction, assess a patient, do a handoff, give feeds, document everything, and maybe even once in a while get a chance to go to the restroom. Next slide. Physicians also have to round, examine, meet with families, document everything, do resuscitations, teach med students, lecture, procedures, restrooms, etc. All of these things are important, and they can distract us from the quality of care measures on which we also need to focus. And it can come at a great cost, both personal and financial. So in front of you shows that whenever there is an issue with the quality of care, including issues with problems of a urinary tract infection, ventilator-associated pneumonia, central line-associated bloodstream infections, or unplanned extubations, and you can see there that each of these conditions come with an additional cost for that condition, and that cost is added to the cost of the care that the patient's already receiving. Remember that last one, the unplanned extubations of $36,692. We're going to talk about that a little bit more. But that additional cost also has pain and suffering and length of stay in the hospital. So the way it worked was that we would do extensive chart audits and we would do incident reporting that would generate data on how well we are achieving our safety goals. That would be time consuming, it would be labor intensive, and it would be subject to a lot of different human factors. Then we take this data and over time we devise interventions that may be formal education or even a simulation lab. And then we cycle back to the measurements to evaluate how did our innovations do, and that takes more time. So the cycle has one major flaw, and that is time. Every step of this takes time, forcing this to be a reactive process. If there was harm done to the patient in the meantime, it's already occurred. Next slide. You have to go back because you didn't change the slide before, or I didn't ask you to change the slide before. It should be on the next slide. So,
okay.
The cycle that we have been doing in the past typically starts with exhaustive chart audits and incident reporting that generate data on how well we are achieving our safety goals. It's time consuming, it's labor intensive, and it's subject to human factors. We take all the data after all those extensive chart audits, and we do over time devise interventions that may be formal education, email, flyers, simulation labs. And then we cycle back to the measurements to evaluate all of our interventions. The cycle has one major flaw, and that is time. Every step of this takes a long time, and it's forcing this to be a reactive process rather than doing it in a proactive way. If there was harm done to a patient, it's already occurred. Next slide. We used to do it. What we just talked about, it's a very reactive process. It's in a static location. Not everybody gets to see all this data, and it's manually updated. Next slide. So, in real time. Next slide. So we came together, and what we wanted to do was something. I would do. Can you go back one slide? With the arms out. Yeah. Oh, wrong way. There you go. Improvement in real time. Well, we need intervention take place at the same time. And in that point, that's where we get what we want to do, and that is the quality boards. So we spent quite a bit of time designing not just the software parts of the board, but what we wanted to measure. We asked both unit leadership and rank and file nurses, therapists, and physicians what was important to follow on these boards. We received great innovative and intuitive input from them. And here is what we did. Next slide. The quality board. It's displayed right in the ICU or the unit where the board is located. This is exactly what is displayed right now on the board. New slide. You can see at the top, you can see there's the census, the days since the last safety event on the floor. Now let me explain what that is. PEWS is Pediatric Early Warning Score, and if the score is high, there's a chance of that patient deteriorating. Now this is the cardiac ICU quality board, but it's showing me what's happening on the regular cardiology floor. So if there's a child that's on the floor with a Pew score that's elevated, I can go out there and take a look at that child and preemptively interact and maybe preventing the child from deteriorating. And you'll also notice that it says last refreshed 0 minutes ago. This board refreshes itself automatically every 3 to 5 minutes. One of the columns. So you can see this column is restraints. There are a number of Joint Commission rules that say we have to write restraint orders every certain number of hours, and the board itself looks to see if the patient has restraints on fashion, and if not, it lets us know. Also, is documentation done by the nurses properly? And again, it lets us know. If we take a look at a particular row, like the patient in room 371, we can take a look and see, is that patient particularly taken care of or not? Next slide. So what we see a mark or an X, it's simple. And if we see a red X or a red number, we know we've got to do something. If we see a check mark that's in green, then we're cool. But it's quite complex. Next slide. Algorithms that have been researched and then rigorously tested to ensure the integrity of the data. These algorithms make sure that all possibilities are taken into account so that we don't get false positives or false negatives. Next slide. Used and utilized, and what are the outcomes? Next slide. So first we needed to figure out how to incorporate this into our workflow. One of the things that we've found is that doctors and nurses don't want to change their workflow, even if it's really great-looking technology sitting right there in front of them. So what we decided in the cardiac intensive care unit was that before rounds, which we do twice a day, the physicians and the nurses will do a safety huddle. We've been doing that for quite a while, right in front of the board, and we talk about safety issues. And then in front of the board, while we're there, we look at the board and we point out issues that need to be taken care of. This is done twice a day, and the physicians frequently look at it much more often than that. And that way we were able to incorporate it into our workflow, which made it a lot easier to utilize this new technology. Next slide. Which is the surgical care unit. The bedside and the charge nurses huddle around the board once per shift or twice a day. And they take a look, and all the red X's are called out with the bedside nurse explaining the reason. Nurses into making sure that they don't have any red X's. Full public view, and that's on purpose. If a parent approaches me and asks me why there's a red X on my child, that's what it's all about. It's all about advocating for the child and making sure that the patient is taken care of. Next. So not only is this created for large screens, like you saw on the wall there, but also it's focused view so that you can pull it up right on any computer within the institution, and they can apply the quality measures to any patient population. That you can pull up your patient list and only see your patients. And when you only see your patients, then it's much easier to look at this. And you can apply your patients to other quality boards in the hospital's parameters to see how your patients are doing on somebody else's parameters, and sometimes that's beneficial. But let's focus on that red 9.5 that you see on the screen under the category of ET tube. Next slide. At the 9.5 is in red, and if you hover over it and click on it, you'll get information as to what is wrong. Here it says check endotracheal tube placement and update placement, distance, and tracks. The endotracheal tube placement value is 9.5, but the placement distance ordered is 9. And I want to explain what that means by going to the next slide. Oh, shoot. I'm sorry. Where students can pull up the quality boards on any computer in the hospital. They can also apply their quality measures to I can focus in on my own particular patients, on my patient list if I have one. And also you'll notice if I hover over a red number, you get information telling you exactly what it is. For instance, this one says check the endotracheal tube placement and update the placement distance in TRACS, which is our healthcare record. Endotracheal tube placement value is 9.5, but the placement distance ordered is 9. And I'll go into that a lot more extensively in a few moments. By the way, the blue hyperlink takes me right to where I need to do my charting. Okay, so there's a 5-day trend. And on that 5-day trend, we can see a little spark line to tell us how we've been doing real-time, real updates as to how we're doing rather than going back to do chart audits. And it also gives us the previous month's compliance as to how well we were doing. And that's there for us to see, for the families to see, and for our leadership to see so that we can make sure that we stay on top of things. Next. Remember that endotracheal tube placement that we saw before. In this particular case, there's this red 6 there, and I'm going to tell you a little story. When you have an endotracheal tube in place, it's very, very easy for that tube to slip down too far, especially in small children. And what you're seeing here are 2 x-rays of endotracheal tube positions. So when we put that breathing tube in, the tube has to go into a point where it's below the vocal cords, but above where the trachea or the airway splits. And if it's too high, it could accidentally come out, causing significant injury to the patient if the patient doesn't breathe well. Or if it goes in too far, it can only ventilate one lung, as you can see on the right, and we lose ventilation on the other side. So I had a child in the cardiac ICU who was a newborn and was born with a very significant congenital heart defect called hypoplastic left heart syndrome. He was going to be going to the operating room in the next day or so to have his first stage of his palliative surgery. A brain MRI on these children prior to going to the OR to take a look at the status of the brain in these babies. The problem is that it's hard to monitor the children in the MRI scanner because with the magnet and the radio frequency, the very close monitoring we have in the intensive care unit is not as good as we would like it. So when we go down to the MRI, the children are not as well monitored as we'd like for them to be. So this was when we first put up the quality boards, about 20 minutes packaging up the patient to go down to MRI, and the patient was on a ventilator with the breathing tube in place. And I happened to notice on the quality board that the endotracheal tube position was red. So I asked them to stop, go back in the room, we got a chest x-ray, and the endotracheal tube was so high that it was almost ready to come out. The importance of this is that had the child been in a not well monitored environment like MRI, that tube could have come out without us knowing it, causing significant harm or even death to the child. So that's we were monitoring may have saved that child's life. Next slide. And really, I need for the computer system to tap me on the shoulder and say, hey, you might want to take a look at this, or this needs to get done. We all are so busy. Next slide. So stories are great, but they're anecdotal. Does this prove that this improves care? Does it prove that we are able to change outcome? And what I've told you so far, the answer is no. But we decided that we would study this to see if it actually does make a difference. Next slide. So when we did the very first quality board in the unit, which is different than the pediatric cardiac intensive care unit, and we studied the effectiveness of the quality board before and after. That were included in the analysis, and they were divided into 3 time periods. Period 1, before the quality boards were turned on. Period 2, immediately after they were turned on. And period 3, 3 months after turning it on, and with education about how to use the quality board. So there were 150 patients in each phase. Next slide. And these are results that we published, which showed a drop in catheter-associated urinary tract infections by 30%. Urinary catheters were in place for more than 96 hours. Those were dropped by 11%. The point here being the longer a catheter stays in, the more likely they are to get an infection. Patient improved from 80 to 93%. And the time to achieve consent for certain things to be done in the ICU was decreased by 49%. This was accepted for publication and was published in the Joint Commission Journal on Quality and Patient Safety in September of 2015. Next slide. All right, that's good, but what else? Well, here's what else. In the cardiac intensive care unit, this is data that I want to show you that was not published data, but data that we've obtained from the quality boards about how well we're doing. So if you take a look on this graph, there are 3 time periods, fiscal year 2014, 2015, and 2016. And on the left side, the y-axis is the number of ventilator days, and on the right side is the absolute number of unplanned extubations, meaning the breathing tube accidentally coming out in a situation that I described earlier about the child in the MRI. So before we turned the quality boards on, we had 10 unplanned extubations. And those extubations cost money, if you remember from what I was talking about earlier with this slide about the cost of problems. But you'll also notice that while the orange line, which is the unplanned extubations line, the absolute number comes down, the number of ventilator days actually went up. So the rate per 100 ventilator days, which is the way we measure this nationally, went up dramatically. Yet our rate per 100 ventilator days of accidental extubations went down dramatically from 0.28 per prior to 0.13 per 100 ventilator days. And if we apply that rate to the increase in the ventilator days, it would have been 13 accidental extubations had we not implemented the quality board. 7, and if you multiply that by the $36,392 per event, that's $1,000 saved, and by the way, potential morbidity and mortality as well. Okay. Surgical care unit where the nurses have to defend their red X's that I mentioned before. And are before the quality board went up, and the orange bars and the gray bars are 1 month periods after they went up. And you can see that both documentation of catheter care, documentation of activity, documentation of intake and output, and documentation of weight improved dramatically after the quality boards went up. The real improvements that were probably statistically significant were catheter care and weight, and maybe activity. Intake and output was already well documented, but it still did go up. So I've shown of how these quality boards have actually improved care. They've lived up to their potential. Okay. New slide. So one of the things that we want to do is we want this to expand, but we have to make sure that on one computer database at one hospital, the examined is as the terminology for the field to be examined at another hospital. So what's called a sodium at hospital A is also called a sodium at hospital B. And so we're working with Cerner Ontology to better standardize and map that terminology. We want to expand, and in fact we have. This has now been installed at an adult hospital system called Nanticoke Memorial Hospital in Delaware, and they are using it and happy about it. We also want to continue our research. I think it's important to understand how to implement this technology, and working with human factors and human behavior to make sure that people actually use it. So we are currently doing a study on one of our hospitalist awards for exactly that, on how to implement the technology. We have been recognized by a number of different organizations. Just to point out, we are a magnet hospital. When they came back by for recertification, they saw our quality boards and they absolutely loved it. The DC Hospital Association has given us a safety award, and we were finalists in the 2017 Greater Washington Innovation Awards for our quality boards. We've also had articles about them in Politico, as well as a HIMSS publication. Have a great day.